Good morning, everybody. I am Stephen. At over the past decade. Um, when Dr. B kind of started this a handful of years ago, he left it open to the chief residents to talk about something that they felt, passionate about or enjoyed. I think Kelsey's presentation was mainly pictures of butterflies and things. So when I started making this, I kind of thought about a lot of topics. At first, I was going to talk about why Massachusetts is the best state in the union. Then I thought about on how to finish. Dr. Tomei enjoyed that one. Then I thought about offering some advice to the co-residents on how to finish general surgery in less than 9 years. But I thought about picking something more universally applicable, not just to me. So I wanted to talk a little bit about the differences and kind of the overlaps and things of ethics, morals, and law, as this is something that we deal with every single day, every single hour. Disclaimers and warnings: I am not advocating for anyone to break the law. I am not an ethicist. Ethics is just an area of interest of mine. And I'll throw this in that there's probably a Western bias to a lot of this. A lot of this comes from Greek influence, and not a whole lot from Eastern literature. So take that with a grain of salt as you will. So the question of what do I do comes up all the time. Little decisions to big decisions. We get told a lot of things in the media. Just do it. Probably not a good slogan for surgery. Spike Lee says, do the right thing. If you haven't seen this movie, younger residents, med students, definitely worth a watch. So what is the right thing and how do we decide that? So when we talk about morality and people's own principles, values, beliefs, this is what you consider fair, compassionate. This is largely shaped by your upbringing, culture, religion, even if you don't recognize some of the things that it's kind of crept into. And the important differences when we start talking about morality and other things is this is going to vary from person to person, even within the same culture. This is going to focus on individual conduct and reflect personal values and principles. So very personal. Ethics, on the other hand, is a universal standard of conduct that we try to establish. These are guidelines for evaluating what is morally right or wrong in specific situations. So ethics, been talked about for thousands of years, from Aristotle, Immanuel Kant, John Stuart Mill, Plato, Confucius, and all of these guys tried to come up with, and yes, they are all guys, tried to come up with, different definitions, their own philosophies of what ethics really means and how to guide us. Spinoza is probably best known for his treatise on ethics, and he was one that tried to unite God and nature, which he pretty much used interchangeably in that essay, whereas you can find ethical joy in the intellectual love of God. I thought that was a very profound statement, but doesn't really give you a whole lot to go off when you're deciding what to do with patient care. Aristotle simplified things. He said, this is just a study of how to live a good life. And I went to Amazon and it turns out you can actually buy a guide on how to live a good life. So anybody who wants that, it's made easy. Laws are different. These are rules and regulations that have been established by governing authorities. So these are enforced by the government, speeding tickets, things like that, rigid, formalized. You do this crime, you get this punishment, and you go on trial. It's fairly right and wrong. Protect rights and regulate conduct, right? We don't want some people going 80 miles an hour on these side streets. Well, we are going, 30. So we all agree that it's probably better for all of us if we agree that the speed limit's 30. These are particular to that system. Obviously, the penalty for stealing in the United States might be vastly different than countries across the world. Same crime, but much different punishments, because this is our kind of man-made governmental constructs. So we're lucky that law and ethics, since they were kind of used with each other, they agree almost all of the time. But we find ourselves in some situations where with either changing times, changing technologies, or maybe not the best insight at the start of things, these don't always line up. And I hope that the takeaway from this talk is that everybody starts to think about these ethical situations in a new light. I think making a legal decision is often far easier than making an ethical decision. But the way that we change laws is advocacy, and that requires all of us to participate in these conversations. And we can change laws to be more ethical. So I want to talk about a couple of cases, and we'll go over some thoughts and hopefully change, maybe not change the way, but kind of reveal some insights into how you're thinking about these. A lot of our training early in medicine, I think, has a little bit of religious bias or other biases that we're not all aware of. So we're going to say that you have a patient, adult Jehovah's Witness with an infrarenal AAA. The anatomy is perfect for an EVAR, best you've seen in a long time. You've been doing this for a while. You're kind of going through the consent. You've done this a million times. During the consent, he just kind of makes a spontaneous admission that he doesn't want any blood transfusions. So you kind of, it takes you a little bit off guard. You just kind of skip the discussion of converting to open because it's been years since you've had to do that. His anatomy is incredibly favorable. He's got a baseline hemoglobin of 16. So right now you're all thinking, well, I wouldn't have skipped that. So yes, you do have to play along with my scenarios a little bit. I get to make the rules. So does anybody, or we're going to keep going here. So intraoperatively, a patient becomes hypotensive. He has a rapidly enlarging retroperitoneal hematoma. And you're looking at this, you know, if you convert to open and transfuse, you can get this patient through this operation safely. So very quickly, you discuss with the patient's wife, who's not a Jehovah's Witness, and she says she will sign permission and urges you to open, transfuse, do whatever you have to do to get through the surgery. So here are some options of what you can choose to do. Assume that the patient didn't fully appreciate that he could lose his life without a transfusion. Proceed to transfuse as clinically indicated. Since you did not specifically agree to withhold transfusion during an emergency procedure, go ahead and transfuse. Transfuse on the wife's authority. Transfuse and do not tell the patient, or do not violate the patient's autonomy by transfusing if he dies on your table. Anybody want to, you can just give a letter of what you would do? E, so you guys are all just going to let this guy die on the table. So you're going to do everything you can medically. You're going to try and finish your procedure. Sure. So a lot of Jehovah's Witnesses are okay with albumin. So kind of stick within the constraints of what is acceptable to him. No one's going to transfuse on the wife's authority. She's giving written permission and say, you know, he told you he did not, but you did not document it. Nobody's going to transfuse. You're all just going to let him die. Paul, you're going to transfuse? You're at a hospital that doesn't have cell saver, Paul. Anybody can transfuse and just not tell the patient? My older brother, when I posed this to him, he's a physician's assistant. He took it one step further. He said, I'm going to transfuse. I'm going to tell everybody in the room to look away. Nobody's going to know about it, and I'm not going to tell anyone. Said, you've managed to ignore all of the options and find something even more unethical. So kudos. So I would agree that the most ethical choice in this is to agree with the patient's autonomy. And yeah, like Dr. Cohen said, just do everything in your power to get through that operation, albumin, pull out all the stops and tricks. But if he bleeds out, then you have to live with that consequence. Obviously, this is a case where you should have had a more thorough informed consent process. But the topic of Jehovah's Witnesses and blood transfusions comes up frequently. And I think a lot of us are pretty quick to say, yeah, but in a situation where, you know, your life would end, would you want it? And for a lot of us, it seems, you know, like a handcuff on us in surgery to not be able to transfuse for bigger surgeries. I remember one of our colorectal surgeons was going to do an APR on a patient that was a Jehovah's Witness. And, you know, for, you know, big cancer surgery, obviously the patient had several preoperative visits. And the Jehovah's Witnesses, it's a pretty tight-knit community, and usually they have a liaison for medical decision making, and a lot of community that accompanies them to these visits. So it was thoroughly discussed with our colorectal surgeon, but I'll never forget the patient expressing her gratitude and saying, I just want to say I'm so thankful that you're comfortable doing this without blood transfusion. To which he said, just to be clear, I am not comfortable at all. He said, I would always prefer to be able to give blood, but I respect your wishes. And, you know, I think we've discussed it, and that patient's surgery went well, didn't need any blood, which I think he was then afraid that he was just going to end up with a whole bunch of Jehovah's Witnesses at his door. But transfusing Jehovah's Witnesses, this is something that they take very seriously. It's something that gets renewed yearly and discussed ad nauseum within their community. So it's not something to be taken lightly. And it should be, you know, a lot of religions have morality or ethical issues of their own that they do not want to break. Any of the med students know who Bob Marley is? Do you guys know how he died? Yeah. So if he had agreed to an amputation, there's a lot of speculation about, you know, the melanoma being cured and him living. But because of his Rastafarian beliefs, he didn't want to dismember the body, and, you know, the melanoma metastasized. So Jehovah's Witnesses feel very strongly about this, and you may prioritize mortal life and extending that. But in a lot of their eyes, if you transfuse them and get them through the surgery, you've hurt their chances for an eternal life. And their beliefs should be taken into account for that. Case number 2, this is a 90-year-old male with diabetes. He's got unresectable esophageal cancer, end-stage COPD, relentless arthritic pain. And he comes to the clinic, and he's pacer dependent, and he wants you to deactivate his pacemaker. So you know that this will likely precipitate his death probably within 48 hours. You ask if he knows that. He's thought about it a lot since he saw you 3 months ago. He's been seeing his psychiatrist. He's been deemed mentally competent. And he's been following with the pain clinic. They have tried everything, and nothing has worked. So you can comply with his request and just turn his pacer off. You can inform him that barbiturates are the preferred drug for suicide and give him a prescription. Refer him to a physician in Oregon who will comply. Seek emergency commitment to a psych unit with suicide precautions. Or tell him that you cannot violate good medical practice by an action that would be harmful. So in this one, you did not skip any informed consents. This patient is in your office. Anybody turning off the pacer? Dr. Marsh is turning off the pacer. Dr. Graves is turning off the pacer. People want to inform him that barbiturates are the drug of choice and give him a script. All right. Norsini, no. Refer him to a physician in Oregon. Seek emergency commitment to a psych unit with suicide precautions. Anybody think that's reasonable? Tell him that you can't violate good medical practice by an action that would be harmful. Anybody doing E? So A would be the most ethical choice. to turn off the pacer and let the patient die. B, C, and D are all not ethical choices for violating patients' autonomy. Sending him to Oregon, especially from West Virginia, is going to add a whole nother level of emotional stressor. E is an interesting option. And I think E would be acceptable if you're willing to refer him to another physician that he can get in and see quickly. We're often taught in med school, the first rule of medicine is do no harm. And that's been a hot topic in physician-assisted suicide. And I think you can make an argument that prolonging this man's life against his will is doing much more harm than turning off his pacer and letting him die on his own terms. So these are changing fairly rapidly. I think that would be a state to state. I don't think that's been federalized yet. Yeah, I'm not sure about West Virginia. Before you did this, I think you would want to talk to your legal department. But I would say that without a doubt, no matter what the law says, the most ethical choice is A. And I think that we come across this situation much more frequently than we realize in trauma. Patients come in frequently, arrest in the field, get CPR, intubation, show up in the SICU, 90 years old with cancer, but obviously we don't know any of that at the time. And the family comes in and says, oh, they're DNR, DNI. So, I mean, what do you do? What's the most ethical thing? No, but you prolong just suffering. So he's made his wishes known, just like a patient, that's stable on a vent, ethically you should remove the ventilator and let them die.
Well, the problem was our policy taught us that we need an actual CNR thing to work with us. Otherwise, you have to wait until you get that confirmation that actual documentation. Well, the nurse comes out to the document, have it, and yeah, it goes back. And so eventually we got there, we got to the hospital, they found the doctor that stopped. But yeah, but it was a very, very lesson I did. I definitely kind of struggled with that one first. But obviously, I want to honor the safety. I want to go on with also about it. But that's a very good I personally did.
Yeah, and that gets into a whole added layer of complexity as far as written wishes and living wills and things that is going to be outside the scope of this, because we're going to assume that we know the wishes, and obviously that is not a real life situation all the time that we deal with. To Dr. Dudis's point, I think most of the laws that I've seen do come down to some of the nitty gritty on physician's intent in those situations, as far as whether the intervention is technically hastening death or palliating discomfort. And those are walking a very fine line in a lot of these, and that can be the difference between legal and illegal. Any of you guys know how to turn off a pacer? I guess we're getting to the point where some people in this room might not remember August 29th, 2005, which is scary in itself. think that was my first intern year. So Hurricane Katrina, this is, most of us remember watching the news reports before it even made landfall, knowing that this was going to be disastrous. But this is a very real life situation that did happen, that you just never know when you are going to be brought into one of these situations. Dr. Anna Powell was a ENT surgeon at one of these hospitals in New Orleans. And I won't go into all of the nitty gritty details, but essentially what happened was they went through with their evacuation plan. And things at the start were somewhat smooth, just like pretty much everywhere. But very quickly, resources ran out. So for the first 24 hours, they were on a backup generator. There were still some helicopters coming to evacuate patients. The water levels kept rising. They rose past the second floor where the emergency generators were, and the emergency generators went off. So the ventilators turned off. Nurses, staff, anybody were bagging patients to just keep them alive. Some of them were being bagged for over 24 hours. The helicopters were coming less and less frequently. And the top floor of this place was like an LTAC with some chronically ill patients. The evacuation route that they had to pass patients through to get them to the helicopter included a window that was about, they said 3 feet by 3 feet, that the patient had to be passed through on a stretcher. Anna Powell was one of the people that was directing this evacuation. And she realized in those first couple of days or first few days, while things were getting really bad, that all of these patients were not going to survive. There was just no way that they could all be evacuated. They were running out of food, water, supplies. And she made the decision to inject several patients with a combination of morphine and midazolam that she likely knew would be fatal. But the alternative was letting them die, fighting for breath, or starving, not being able to get through. One of the guys was an amputee with, body weight of 300 pounds that she never thought could get to the helicopter. So after Hurricane Katrina, the government came in and all of these hospitals had a lot of deaths as predicted. But this particular hospital had more than they expected. So they investigated it, and that's when they found these combinations of lethal drugs. The DA tried to prosecute her, and the grand jury did not follow through on that indictment. So I believe she is still practicing. This obviously became quite the debate over what you would do in that situation. People can paint different shades on it and give their different spins on what they thought was happening, but I think it's a very enlightening or harrowing conversation to have of if you are the one that has to make that decision of patients suffering. And obviously she had to make calculations on what she thought the survival hood was like. And I can't imagine being in that position. I won't get into whether or not to agree or disagree with what she did, because I think without knowing all of the facts, which having read through court reports and popular press articles, I still don't think we know exactly what happened there. But when you put yourself in that place, it's pretty hard to think about. So this is a quote from Christian Bernard, that I believe that often death is good medical treatment because it can achieve what all the medical advances in technology cannot achieve today. That is to stop the suffering of the patient. I remember my first day, I think as a first-year med student, shadowing, my first shadowing experience at a family medicine office. And I just met the attending, and we were getting to know each other. And he just kind of says, "How do you feel about physician-assisted suicide?" I said, well, I think that's, first I was like, wow, that's quite the icebreaker. I said, that's a very complicated situation. And I was starting to give a long spiel and he goes, no, just for it or against it. And I said, well, I guess if you're going to force me into a corner, I'm for it. And he goes, oh, not me, I'm against it. I mean, do no harm. That's the first rule, right? And I was like, all right, well, this is going swimmingly for my first clinical experience. And this thought of death as the enemy and the ending of mortal life comes from a lot of morality and comes from a lot of religious teachings, and it crept its way into ethics for a long time. Plato in Phaedo says, this is like akin to taking away God's greatest gift, and you're going to offend God. And I think for a long time it bled into medicine that this is like the absolute enemy, when it should really not be thought of that way in every situation. I think that the question of physician-assisted suicide is one that's going to be revisited often in the near future, with some caveats made that physician-assisted suicide is not akin to euthanasia. This is not the doctors administering the drugs. This is allowing patients to end their lives on their own terms without having to go through more brutal or scarring ways of suicide that will affect their families. And my favorite quote that I think about often is from René Lariche. Every surgeon carries about him a little cemetery in which from time to time he goes to pray, cemetery of bitterness and regret, which he seeks the reason for certain of his failures. And think about that quote often, and I think we all go home at the end of the day and we think about patient care decisions we made that we wish we could have back, going to the OR earlier, not going to the OR. There's really no end of the things that we do think about. And I think we all need to take a closer look at some of the decisions we make ethically. Just because it's the right thing to do legally doesn't mean it's the right thing to do ethically. And we should all be doing the legal practice. But if you run into those situations, those laws are only going to change if we all start bringing it up and talking about it and having that discussion. So within the realm of medicine, the greatest act of compassion lies not in the pursuit of endless life, but in honoring the dignity and autonomy of each individual, even in the face of death's inevitability. Balise, 2024. To see Barb? And I'll also put a disclaimer out there that Dr. Hill is somebody that I've gone to with some of these questions and conversations. She's an amazing resource for the department. And if you ever have questions regarding things like this, go talk to her. You'll learn a lot.
Stephen, thanks for addressing or starting this topic. This is obviously scratching the surface of something that is a lifelong process to think about. I just want to raise a point for the residents to think about and start a discussion maybe when you're in peds. You can go through the same process now and just replace these 90-year-old patients with 16-year-olds. And that opens an entire different discussion, thought process. What if the 16-year-old is a kid with cancer who is Jehovah's Witness and does not want the blood? Or what if he is not even a Jehovah's Witness? What the parents want are Jehovah's Witnesses and want him not to have. This is a regulated by law. To give the short answer, a minor is depending on the age, can make independent decisions also against their parents' will, but it is something that you should think about. What would you do if they were kids?
Yeah, so in my disclaimers, I almost put it in and I forgot to add it. I specifically did not talk about kids because that is a whole other layer of complexity that I was not going to get into. Because like Dr. Seifert said, that gets incredibly, I mean, it's already complicated enough when we have a full-grown adult who can communicate their best wishes. Increasingly, infinitely more complicated when you have somebody that is communicating like an adult, but maybe their brain isn't fully formed yet, and you have to take all these things and the parents into consideration. But I guess ethically, in peds, especially with the more adult children, keeping in mind that they're the patients and not the parents.
Stephen, were any of your scenarios real? Or those were created, like contrived?
You mean like from my real life experiences?
Your patient scenarios, yeah.
These were examples taken, both of those, or the first two were examples taken from a book on surgical ethics.
Okay. I just asked, when I was a resident, they talked about a few years before I was a resident that there was a kid who was a trauma patient and ended up getting transfused against the parents' wishes. And then the parents left the kid out in a snowstorm and he died. So just with even your husband's situation with the EVAR, what would he do, if you transfuse him and then he wishes he hadn't been?
So it brings up a great point of medical surrogacy and the fact that we use surrogates to make decisions very frequently. There was an article in JAMA, it was in the 90s, so it probably needs to be looked at and studied again, but they found that surrogates misrepresent the actual wishes of the patient about 70% of the time.
So I had a case like your first case. I've often said, what's dumber than transplanting a Jehovah's Witness, doing a liver transplant on a Jehovah's Witness, and that's retransplanting, doing a retransplant on a Jehovah's Witness. So one of my colleagues transplanted a Jehovah's Witness, and then he left town, and the patient had primary non-function. So I retransplanted the patient, and like you said, they always have a representative from the church come and sit with the family to strengthen them. And so the husband and the mother were not Jehovah's Witness. So they went to court and got a court order to transfuse her hemoglobin is 3. So the representative of the church, and you do get these patients because they tell everybody. So I had several of them, and I had worked with him many times, and he came and he said, I thought you respected our wishes. I said, I do, but I'm not going to jail for them. And we have a court order. And so I didn't get any more patients after that. But I mean, that's how seriously they take it.
Very, very seriously. Yeah.
And she died because we didn't get the court order in time.
Dr. Drebby was certainly afraid that he was going to become the APR guy for Jehovah's Witnesses. I will say I've got one anecdote that kind of follows that from when I was in Vermont. We had a patient that was a sickle cell patient, came in with a hemoglobin of about 3, and they wanted to transfuse, and he said, I'm a Jehovah's Witness, I don't want blood. Given that it's Vermont, they do not have a robust population of sickle cell. So this gentleman was very well known to the hematology oncology department as like one of 3 cases that they treated. And the question came up of, well, he's sitting here, he's telling us he doesn't want blood, he's Jehovah's Witness, we're not going to give blood. Somebody said, well, do we know he's thinking clearly? His hemoglobin's 3. And they called the hematology attending that had taken care of him. And he said, I'm getting on a plane, but my fellow's there. My fellow knows him really well. So the fellow walks in to talk to him. He starts talking, and the guy looks at him and just says, who are you? So at that point, they said, okay, well, we don't think he has capacity. They held him down and transfused him. And the next day, when his hemoglobin was more appropriate and he was thinking clearly, he thanked everybody in the room and said, I know what I said, but I appreciate you saving my life, and I'm glad I'm still here. So, this is why these are hard conversations and hard situations. That gets down to personal morality and how strong your beliefs are, which isn't for anybody else to comment on. And that's why we keep talking about these things.
I think that's a good point. Not to go down a really radical debate, but I think gotta assess the individual level, because, okay, you know that Jehovah's Witnesses don't take blood transfusion to explore without practice, but not everyone is without practice. There are plenty of Catholics who, do not participate in that, and not only sit on Friday. That's a personal choice, so I think, you know, you can't just assume, you couldn't assume this, that they won't want blood, that's why they're always, into that conversation.
Yeah, and when I was typing up the first scenario, I was thinking, all the surgeons in the room are just going to say, well, it's a boneheaded move to just not go over to the informed consent because you can save yourself all of this headache. But you're right that, and there's having the liaisons there is very helpful. Having been in clinic with them, and a couple of years ago we had a patient with bad pelvic fractures in the SICU that was Jehovah's Witness and didn't want blood transfusions, and their hemoglobin was downtrending. And like Dr. Cohen said, there are adjuncts that you can use sometimes, like albumin, and technology advances to Cell Saver, and there was some kind of plasma expander that Pittsburgh had that we didn't have. So I worked with the medical liaison from the Jehovah's Witness community, and we transferred the patient to Pittsburgh where they could give him this plasma expander. But certainly something, that I witnessed with Dr. Drevy was just the extensiveness and exhaustiveness of this conversation and documentation. Because like I said, I'm not advocating breaking any laws, but we need to protect ourselves too, just like, when Dr. Marsh gets that court order.
Thanks, Stephen. Two comments. One, in the conversation with Jehovah's Witnesses and anemia and blood transfusion, sometimes you'll be surprised what an individual patient can tolerate. We don't really know what the lower limit of anemia is that is compatible with life. We're taught to transfuse at 7, but that's because that's the cutoff that was chosen in that study. So maybe it's really 5. But I had a patient in residency who had a big upper GI bleed, was adamant she didn't want blood. Her hemoglobin, her hemoglobin was 3 and her creatinine was 3, and she left the hospital and was fine. So you never know. And that's kind of one thing that I always think about. And you can definitely support them with fluids and pressors and things that are counter to us, because that's not the way we resuscitate hemorrhagic shock, but sometimes it can be done and you may be surprised. And the second thing was, I was going to say some of the similar comments about pediatric patients. I think personally, it's a lot less distressing to me to follow the wishes of an adult who's made very clear prior to their surgery what they want or don't want. For me, it feels very different if it's a 5-year-old that's in hemorrhagic shock than if it's a 55-year-old who told you what you want. So I don't know what the right answer is, but it certainly feels different to me.
Yeah, it feels a lot different. And that's something that you could debate for a long time. I think, with an adult that has strong enough beliefs that they do not want to be transfused and they're willing to die for it, I think we can all say, well, that's fine. They've thought about this. They know the consequences. And those are their views, be them religious, spiritual, what have you. When it's a 5-year-old that hasn't really had the chance to form their own views, and you're going off of just parents' views and whether or not that should deprive the child of a chance to form their own views later in life. Like I said, I left children out of this on purpose, far more complicated. Like Sprando said, that could be an entire grand rounds. So. So your point about